Welcome. Good evening, everyone. Happy Monday. I'm saying that as I look forward to Friday, but nevertheless, I hope everyone's doing well. I appreciate the flexibility, and please, I can pivot in any direction that is most of interest. It's late evening, so I understand that I don't know about you all, but I have a lower threshold for just a lot of yibble to yap. So I'm going to try to do my best to make it most palatable and so hopefully something that you find interesting. So and I hope because I have to admit some of the information that will be providing for lack of a better term, I won't say a road show. That sounds way too sophisticated, but I am as much as I possibly can because of what we're experiencing in the pandemic. I have said some of the things that I'll say in different forums. So I don't know if people have been in other areas and have heard it. If you do, for some of it, I don't apologize because I just want to reinforce it even much more. With your permission, I think what the way I'd like to start is just globally giving you a sense of everyone knows, obviously, we're in a pandemic, but maybe some updates in terms of the county and county behavioral health, if that would be helpful. I think we pretty early on in the pandemic, and it's interesting. I think that the last time I was here, I don't remember whether it was COVID or not, because we were virtual. So I'm pretty sure that it was. But I think okay, good. So when I had come before, we were just starting into the process. And since then, over the last year, some of the things that we've been doing is number one, behavioral health has the whole time been engaged. We are considered essential services. We're those emergency service workers. So I myself, it's evening, so I'm home, but ordinarily myself and other staff have been in the office and continue to work. And a majority of our staff are mostly working either on site or vice versa if lives have changed, but many of which have been deployed. And so literally some of our physicians, our nursing staff and others have been at the Coliseum and other places, literally providing vaccinations to our clients, the community. So from day one, besides changing our policies and practices to be a little more uh, telehealth friendly and as flexible as we could, our staff actually have been doing some really important work in the community. So it is obviously my pleasure to be here in May. May is Mental Health Month, and I also want to acknowledge that this is also Asian Pacific Islander Week. Heritage Week. So that's something we want to celebrate and recognize, particularly what we're seeing in terms of the atrocities, both against the Black community, the Asian community. But there's a lot going on this year. So I will start with number one, as I mentioned, talking a little bit about what we're seeing so far, and some of that will be data. If it's useful, feel free to let me know, and we can certainly put it in hard copy. But overall, we did see this is everything in terms of across the board countywide. So not just in this particular area that many of you may be living in, but we saw about a 19% reduction in our children's system of care. So that's reduction in clients served as a previous year. So if you look at the same time frame pre-pandemic, we saw about a little shy of a 20% reduction. We also saw in overall for our children and youth about 11% reduction in visits. So most of which, as you can imagine, for school-based services, there were no schools since the last time we met in many cases. And they've only recently, within the last few months, for the most part, began to do hybrid learning. So we're seeing slightly an increase. We were even able to isolate some of that data because we're following the trends. Organically, I'll say first, what we're seeing is that even though the visits have decreased across the board, the need and the actual experiences have actually been more complex. So, for example, that might mean we may have had less crisis calls, but when people are calling for crisis, whether they're clients and family members, the issues have been much more complex and intense. And so they may have had to go to John George. We have lots of different programs. So pleased to say, after we met, we were able to launch our CAP program, which is our community assessment and transport team. And that is when 911 is called, although we have law enforcement there on deck, that team arrives, and that is a partnership between emergency services, EMS, essentially an ambulance person, and a clinician with Bonita House. And so we will arrive, and essentially the law enforcement is not needed. And our goal is to provide a clearance in the field and to take the person wherever they need to be, whether that's John George, and in some cases it's not, it's somewhere else, but it's a transport team. And so they actually have SUVs all over the county. It's been so successful. We're already seeing a huge impact to John George, which couldn't come at a better time because obviously in the pandemic, with what I just mentioned, people are having more complexities at the hospital. But this has seen a diversion to John George and a decrease in reliance on law enforcement. The other thing that I think you and your community may be interested in is um, how do I say this? In most jurisdictions, in most county government, especially for behavioral health, it's a person like me, my role as the behavioral health director, we're authorized by state and statute to be able to be the ones essentially to certify who can initiate and release 5150 or 5585 holds. And for whatever reason, Alameda was set up a little slightly differently. Alameda had a historical experience for many, many years of before that occurred to go to the Board of Supervisors. So for whatever reason, it did technically, no, although the supervisors I'm sure would have supported it, should it have been brought to their attention, we had less number of individuals who in the community could release a hold. And so unfortunately, we saw an over reliance again on law enforcement. And so what we've been doing in the middle of the pandemic, thank goodness, we instituted not only a huge turn to telehealth, we started to approve telephonic services. We enabled our peers and family members much more access to reach out. Our community partners gave them as much flexibility as we could, and quite frankly, that the state would allow us to do. And we have, my office has been approving with kind of an emergency based pandemic approval. That's my name. It's not what it says on the document, but the board has authorized us, literally me, to do the job that is in statute. And we have developed a pilot of programs, including Pathways to Wellness, which is in this area as well. Several at La Familia, La Clinica, and some other providers as a pilot program. And we have given them the ability to do just what I've described. Why we think that was helpful and important is because, as many of you know, unfortunately in the community, you have to call police in order to initiate a hold. And for those that do know, we still are the highest in the state of California in Alameda for the number of 5150 holds that are initiated. So those things are happening. We're I won't say excited, that sounds very strange to say, but we're pleased because we think it's the right thing to do, to decrease the reliance upon law enforcement, to decrease and rely more on programs like CAT, more programs like Mobile Crisis. We've done some expansion in that realm. So we're trying to wrap around in terms of what we're seeing.
Dr. Tribble,
Yes.
excuse me, is the CAT service in Livermore, Dublin, Pleasanton now?
We are expanding. Our hope is that it will be crouching there. Literally, we're only limited by three things, as I mentioned before. It's a partnership between EMS, which is actually, and Falk. So for those, if you've seen them driving down the street, it's the Falk ambulance, and that's what is county. So we wait until they're able to procure staff, and then it is Bonita House that has the clinician, and then we have purchased the vehicles. So for now, we're moving toward that direction to have it more available. It's amazing. I don't know for those that remember the Oprah Winfrey show where you have a car and you have a car. We're so excited. We found that there was a lot of interest for us to give and allocate more CAT all over the place. Everyone wants a CAT, so we're thrilled with that. So I have gone to the state. For those that weren't following it, it was a state-approved innovations project with MHSA. So what that means, you actually have to study the results. And so even though I have gone to expand it by about $5 million to pay for the vehicles, to pay for the staff. And as soon as the state approves it, we'll be expanding it. But we don't think because it's doing so well, we're going to catch up with demand. So in terms of the specific area, that's our hope. We're hoping that it will make it there, but it literally is a partnership, and we will not initiate unless our EMS partners can write out, because again, the goal is that it's not law enforcement. We're not creating a MET program, which is clinician and law enforcement. We're creating CAT, which is clinician and EMS writer. So that's our hope. We've also we funded a project at I think it was in the same visit when we, I won't keep saying your green car, and when you took us on that trip, but Axis, primary care. We have also provided them a few $100,000 as a seed project to be essentially a hub, a receptacle of people in the Tri-Valley and Pleasanton area. So if they need help, they can go to that program. So it's a partnership with a few cities in the area, as well as Axis Healthcare Services. And so with the integrated work, we're hoping that they too can provide. And that's a brick and mortar. So that's not mobile. That is actually a facility in that area. So we've been busy over the pandemic in terms of that. So you're welcome. I know. I almost amazing. So what I wanted to also mention is to give you a few more data points, and then if that's hopefully helpful. So as I mentioned, for the first set of demographics that I provided you, that was for youth. As you can imagine, we saw a 20% reduction in clients served in the schools. And ironically, though, we saw a 19% increase in the school visits. So it seems like it doesn't make sense. But what it means is, even though there was a reduction in the total number of clients, the number of clients we did see needed to see us more frequently. And that's a theme we saw all across the board. And that speaks to what I was saying, that qualitatively people are in much greater distress or just have much greater need than they did initially. And we're seeing that in our data bears that out. We also lifted telehealth, and I think when I came last year, we were just starting that. So it has gone across our department to our providers. We've authorized pretty much anyone who's able to make sure it's private and protected and encrypted doing telehealth. We also expanded, we got state approval to allow telephonic services. And for many of you, that doesn't make, couldn't you call on a telephone before? You could, but there were only certain services we could do technically by phone. But the state has allowed us, and then other counties, we were one of the first ones that got approval to do the work we need to, do assessment if we have to. We also basically deputize more of our family partners, our advocates who have always been engaged, but our consumer partners as well, to do much more work with outreach and engagement. So there's a lot of activity happening, and nevertheless, we're seeing across the board, some of those complexities. A couple other metrics I want to say, I don't want to throw, too many numbers out, so that takes the bulk of the conversation. But ironically, in the hospitals, and again, this includes John George, we saw a 32% decrease in clients served. And that's why I started off by saying CAT. That's why I started off by talking about the pilot program, because we're thinking that those things are working to divert people who don't need to be in the hospital out of the hospital. And on the other hand, it is making the way for more people who really have some complex issues to be hospitalized if they need to be, and be supported. And as folks probably on this call know, that i.e. John George happens to be the hub, most people go, and there's often difficulty accessing services. But they and we have been working together and are seeing a difference in that. So that's really important, because the people who need to get served need to be able to be served much more adequately. For the adult system, so that was mostly in the youth. That was in the youth side. On the adults side, the numbers look really a little different. So, for example, there were not 20%, but there was about 6% fewer clients that were served compared to last year, pre-pandemic. And there's about a 3% reduction in visits. So it's almost the same in a way. There isn't a lot of change that we're seeing. But we are seeing organically that the services that are being rendered are more serious, basically. The kind of assessments and crisis management, things like that are more serious. Um, but 74% more clients were seen through telehealth this year during the pandemic than ever before. And you would imagine that, of course, that makes sense. But one of the things that we were concerned about early on, and you all may have been as well, is the digital divide. Not everyone has a laptop. You all and I are resourced that we can see each other. We have phone or we have other things. So we did allow some flexibility with our providers. And for those that are not aware, 100% of our SUD providers are contracted out, 100% of our contracts, and then about 88% of our mental health are contracted out. So individually, if providers came to us and said, we want to procure laptops, or we want to make sure we have phones, we want to get government phones and then help them with Wi-Fi, we were able to allow them the flexibility within their contracts to do that. It's a little complicated for us to be many have asked, have we ourselves purchased phones and passed them out? We weren't able to do that because we're a government entity and there's some challenges with funding, but we were hoping one of our large Silicon Valley or Bay Area, we've got a lot of millionaires, would help us, and we were not successful in getting folks to contribute, but nevertheless, that's how we ended up meeting some of those needs, and why we think there's a huge number of individuals that didn't get served before and now got access to it. We're not planning to discontinue telehealth, and we're still continuing to provide direct services. That hasn't changed. Initially, we all went through it where the buildings closed back in March, April, and somewhat in May. But when they were allowed to reopen, our residential facilities, all of that stayed the same. But with COVID, we did have to provide some consultation and help and work. I don't, you may or may not be aware, but we were, if you remember the COVID quote hotels that Gavin Newsom, our governor, came by to visit, we were there. We don't always get on camera and wave, but our staff were there, are providing services to people who were either positive for COVID with mild symptoms or people who were at risk, homeless. So we were literally everywhere that sadly the pandemic reached and people were in need. The good thing is that we continued to provide the services. What was ironic initially as compared to last year, another thing that was interesting is there was about a hospitalizations for adults, again, as I mentioned, decreased, and it's probably from all of those things that we mentioned, or I talked about before, but there was about a 10% decline in clients and an 8% decline in visits. So again, smaller number of clients and even less frequent number of visits. So that's a good thing. It meant that we were trying to manage them in the community as best we could. And the pandemic precluded us, obviously, from providing as much support as we would have liked to, but we were still able to reach out to them. One of the things that we are continuing to follow and that we're continuing to make sure that we address are as we're returning, quote unquote, we think and anticipate that close to the fall. So hopefully this isn't new information and I'm not sharing too much, but we're hoping that we should be looking at closer to an semblance of normalcy this coming fall. Although the governor has stated that June 15th is when things will, quote unquote, return to normal, meaning the restrictions that California had engaged, according to our governor, June 15th, they will be removed. However, we still believe clearly people have lost their jobs. People are homeless or having some challenges. So we've been working with our offices of homelessness, which is now in Healthcare Services Agency, which is the broader umbrella. We're part of that agency, the largest department, but part of that. So we're still working with them, with our social services. We've been trying to create some new programs that are going to catch people as things return to normalcy, because we still think there's, quote, normalcy is really at this point elusive. And we think we're going to have a huge swath of the community still needing support. Concrete example of that, and I don't believe that we have those data points the last time I came, is in the beginning of the pandemic, at least for 6 months, we saw a huge decline in the number of child protective services reports and the number of elder care and abuse reports. One would say yay, but unfortunately, we knew that wasn't the case when we talked to our partners. And because of everything that I've mentioned, unfortunately, it went underground. So for children, because schools were out, the normal ways where child abuse issues were reported didn't exist. And we also know that without having the ability for people to work and leave, if they were adult caretakers, caretaking older people, there were some incidents. So we were working with our social services partner. They really were leading the charge in doing that and doing a lot of outreach programming. So some of the work that we have focused on is literally in different communities, reaching out to them. We brought them meals just for fun, literally no strings attached. We tried to work with our other partners around providing resources, gift cards, Target cards, so people could just not only spend and be pragmatically on their feet again, but then also connect them to services. So it's been a very, very busy time. So, I would love to share a little bit about the strategies I want to go on the rooftop and talk about, but I'm going to pause. I feel like I've said a lot, so I certainly can pause if there are any questions about the data or anything that I mentioned before I pivot with your permission, if that makes sense.
Yeah, hi, Karen. I'll jump in. This is Liz from East Bay. Just two questions regarding numbers. One, how many CAT teams are there altogether, and the hours? I have two number of questions for you.
Okay, I wish I had more notes with me. So I'm pausing because, how do I say this? COVID has been complicated. So as with any situation, if a person is exposed, which many of them are, we have to pull back our team. So at any given time, we may see plus or minus. I believe at this point, we have anywhere between 5 to 6 or 7 CAT teams out in the community. Wow. And we, again, are hoping for more. And the more, again, as I said, comes from when the staffing of our EMS is with our clinician and when that happens. In terms of, so at any given time, that's approximately how many we have. And I believe we are staffed 7 days a week. And I believe at this point, we have, when that reduction, as I said, sometimes when there is a less vehicles on the floor, we do have a little bit of less ability to provide all of those hours, but they're there on weekends. I believe they're there to early evenings to 10 or 11, but I certainly can get that data specifically from Stephanie Lewis, who is our Division Director of Crisis Services. So the fantastic thing, she's the expert and she's fluent and follows it every day. There's a change and they're on it, so we can get that information.
Thank you. Yeah, I wasn't sure if it was 24/7, and I think maybe 1 or 2 were. The other question I have is, you said that Alameda County had the highest number of 5150 holds. Could you explain more about the fact that our beds are oftentimes assigned to other than Alameda County patients? And is that our number, or is that the number of total beds, say at total holds at John George? How many of those are Alameda County folks?
So I'll work my way back to your questions. All of the beds at John George they don't outsource. We fund them. Although, again, Alameda Health System runs John George, but we fund John George to provide the inpatient care as well as this PES, the CSU portion of it. What we do find, for whatever reason, is that Alameda County seems to be a place where people from other counties end up. And so there may be people from different parts of California, from San Francisco, Contra Costa, from Santa Clara, that do end up at John George for a variety of reasons. When I used to work with AHS, we even had a unfortunate event where there was a person from Chicago. And so we ended up paying for them to be flown back with staff back to Chicago. So there's something to be said about the Bay Area. Probably, again, the climate, even though we all want at least we in behavioral health want more resources. There is way more resources in Alameda County than maybe available to some other communities. The other thing is the 5150 rate, and there's kind of the chicken or the egg. That's been a long-term discussion about why that happened. I'll just give you the facts as I know it. Number one is Alameda County had, particularly at John George, many years ago, began what is called the Alameda model. And some of you may already know what that is. For those that are not familiar, what that meant was John George, previous leadership many years ago, had started a process, and it actually became famous. And it literally, you have people from multiple states touring and wanting to know more about this Alameda model. It's been published. It didn't quite work out the way we wanted to. When I say we, I mean royal we, the county we. Because what it said was we would rather, and it came from a really good place, we would rather people not languish in a hospital, an ED, but instead be brought to a place where they could get support, which theoretically was John George. And so that model was designed to decompress ERs. The problem is ERs took advantage of that. And I don't mean it in a negative way, but they absolutely did. And sadly, we know what it looks like, family members and stigma, that the quickest thing people want to do if they're in an ER is to get the person out. If they have a mental health illness, they want to get them somewhere else. And so we've began to see a huge rise in the number of transports and 5150s to John George. If, for those that followed the news, if you just Google it now, if you remember, the overcrowding at John George happened and continued to happen for many years. And I actually was here, I think the first time, I think as the deputy and the interim director, but that was a factor, the Alameda model. The other thing that's a factor that people talk about, and we never, again, it's the chicken or the egg, is that it's fantastic that we do, but we have across our county what's called crisis intervention training. I'm sure all of you may have been familiar with it. And it may be a double-edged sword, because what it means is, as I said in the beginning, for whatever reason, historically, Alameda had restricted anyone else besides some county clinics and pretty much Kaiser and law enforcement. That's about it. And maybe a couple hospitals to initiate or release a hold. So what that did was overly rely upon law enforcement to do those 5150 assessments. Now I shouldn't say assessments, initiate those hold. California allows them to do that. So we have no jurisdiction over that. Why I say CIT is that with the training, it taught the law enforcement, and most of them are all trained in this, how to recognize mental health symptoms. So as compared to other jurisdiction, most all of our law enforcement have some CIT exposure. Not every law enforcement agency is created equal, but what we found was they will immediately bring a person on George, they will immediately initiate a law enforcement driven hold, more so than any other county in the state. So there's a variety of factors, not having enough people to release holds providers, which we're rectifying, not having or overly relying upon law enforcement, which CAT and other programs we're trying to devise will decrease. And the fact that trying to do theoretically a good job by utilizing the skills they learned in the CIT, they begin to recognize there's many more people who might need help. And in fact, when you tease out the needs of the individuals, they probably were more suffering from substance use issues, homelessness, general concern. And so without many options in the law enforcement's mind, and the Alameda model enabled that to happen as well. So we had a perfect, not so happy storm, but perfect place. And so that's one charge we don't want to retain. And, but it is one of the things, I think many of the things that have contributed to where we stand now.
Okay, thank you.
You're welcome.
Oh my.
If there's no question, I want to jump in if I may. Again, on the 5150 question, I think something to be said about the revolving door also. My son's been hospitalized twice in the last 2-3 months. And there is severe mental illness involved, but because there's also dual diagnosis, right? They clear the drugs, they go, okay, no problem, they let him go. And I have all the paperwork, I'm like, there's a problem, we gotta hold him. And this is an opportunity, this is a unique opportunity, right? No, there's nothing we can do. send them home. And I know deep down this is going to repeat, and it just opens the doors for further damage, further violence. Somebody's going to get hurt at some point. And is there anything we're thinking of doing to change that pattern? Or can
Yes, well, we, for those that remember historically, they're not as utilized as, I hate to even say this, because for those that remember, there is the AOT, assisted outpatient treatment, which can be driven by family members, and there's community conservatorship. And why I say I hate to say I'm gleefully happy, but those were some of the options that family members such as yourself and others have available to them now. That cycle can be interrupted with a court, essentially authority. And we have seen significant improvements. And what happens is the person essentially is identified by the court, family member, or whomever can make the referral. They often are the ones that you just mentioned are revolving. The court orders them to treatment. They're given the highest level of outpatient treatment, which is a full service partnership. All the rights and privileges thereon too. So they may have housing vouchers, they may have everything. And we've already seen some really good recidivism decrease rates that are good. And then the other thing is that we also work with our community, our social services agency partners with around licensed boarding care homes. Some people don't like those, but we've tried to find lots of different options. So that is an option. There's also what's, as I meant, I don't even know if I mentioned it today, but in-home outreach team. And we use that team for basically difficult to engage individuals, people who, for whatever reason, you mentioned substance use, they just keep cycling through. Sometimes they're homeless, sometimes they're couch surfing. We have whole teams in different agencies in all parts of the county. So I think there's several different teams, including the Tri-Valley and other areas, that will go wherever they're at. They'll go to the person and they'll find them. So we do
they
have.
saved me. I have to say,
Oh,
A+ service.
I'm glad.
They're
I'm
my
so
heroes. Along with
Yay.
Marsha and Fazmi, and if it wasn't the community, I don't know what would we do.
That's wonderful. That's wonderful. But it is the truth what you raised. It is where California is. We certainly want to respect the rights of our patients and clients. It does put us in a difficult place. And even John George and other psychiatric hospitals that you're not really able to detain them because it's the right thing to do. It has gotten more complex these days for a lot of reasons. So it doesn't preclude us then from being creative with what programs we can do. But you raised a real point.
I want to point out there is a chat question. Actually, it's one I've been asking for a couple of years now. Is Alameda County applying for an IMD waiver for the mentally ill, not just the SUD patients?
CalAIM, I'm not sure, and that's why I'm pausing. So CalAIM, for those that are following, the state is, layman's term, attempting to redesign everything. We are advocating for, and I happen to be on the state, I was on a state representative of Alameda County when they were finding out what behavioral health needs. And we and others, myself, were advocating for just that. CalAIM is in a position where we believe that that may be ultimately where the state goes, to allow people to be supported regardless. The state, I see that it, as of January 1st of next year, part of the CalAIM begins. I'm sorry, maybe I should read it for those that aren't following the chat. The conversation, CalAIM says it won't get to the waiver for the state for another year or two, but they say counties must do so separately. And right now we're talking to the state about what that would look like, and we're talking to the state about it, and they've not yet given us a path forward on it. But many states, many other counties are in the same position that we are to think it's the right thing to do. So to some degree, COVID has slowed down the process, but we don't think it is off the table completely. So we think that the first doors essentially will open in January for some of the changes for CalAIM, and then there will be another round in June, And then there will be lots of different programs that run out. And then we're concurrently advocating for changing some of the legislation. The good thing is that we think, without getting political, there was a bit more thought to perhaps ensure that there is a welcoming, receptive audience at the federal level, because essentially there are some federal impacts before some of these changes were made. And so I do know that the state was trying to be as strategic as it could, and they believe now that there may be more ear for making this different types of reform than there was previously. So even if the state certainly wants to do that, there are also implications to that, because CMS is to whom you bill when things are changed, and you do have to catch up with CMS to make sure that everything's aligned. So there's a lot of work. I have hope, fingers, toes, and eyes crossed, because no one would have thought that during the pandemic that all the state reform would continue, but it actually has. So that's good indication that we're looking at probably change within the next few years. Alameda County itself, I mean, certainly if there's board support, we're not objecting to looking at participating in any type of reform. We're already volunteered to be pilots in a lot of different ways for CalAIM. So we're super amenable to that.
Are there any other questions? Okay, on to the next thing.
On to the next thing. And again, please feel free to, if there's something else that I can be talking about, please explain what CalAIM is. Absolutely. Now, of course, I cannot remember the acronym, but CalAIM is California. It's, someone can Google it and more probably in real time than I can. But what the state basically did a few years ago, and some of us, have delusions of grandeur that maybe we were the ones that gave the idea. But some of the legislators were asking, what could we do, and what did we think could happen to change our system? And we thought, and we said, if the state could make it easier for substance use, primary care, like physicians and doctors, mental health, social services, for us to be seen as more of a system. And that means breaking down some of those walls for billing. Some of the laws are mutually exclusive. It's almost, in order to be hospitalized, you either have to have a mental health disorder or a SUD disorder. But for example, PES cannot treat and hold a person just for substance use, but somehow you can make it through to the inpatient. None of those things are connected. The waivers, there's a lot of challenges. So that was essentially what CalAIM, thank you for putting that in the chat. There's a lot of information around CalAIM, but essentially that's so layman's way of saying it. So a lot of different stakeholders have been sitting at the table while the state goes by to try to reform it. It'll be changing criteria for eligibility. So that may mean more people will be served. It's also trying to make screening tools and assessment tools much more similar, because as many of you probably know, your loved one is in one organization and they have to fill out the same forms and go somewhere else and fill out the same, tell their story over and over again. And so they're trying to make it much more seamless. And the point is so that the beneficiary, the consumer, the family doesn't have to navigate so many portals and get lost in so many loops. The benefit to our providers is that we'll be able to bill and receive payment for services we've never been able to receive. Coordinating for certain services is going to be paid for. Again, this is layman's way to describe it. When a primary care organization or the alliance, the HMO that serves our Medi-Cal, they may contract with behavioral health providers so that we can be much more seamless, because all the silos the state has acknowledged is negatively impacting clients and client care. So that's why it's exciting. It also has payment reform, but my eyes and my ears explode when I talk about that. They're just going to change the way we bill, which is complicated, and that's a good thing. We're hoping it'll be a little easier to do that. And we had already started that a few years back, so we'll be able to change that way too. So that's essentially what CalAIM is about.
There's another question in chat. The question is, hiring therapy staff is a challenge. Is there any momentum of relaxed telehealth rules to allow for out-of-state therapists to provide services in Alameda?
Good question. The state has not gone that far to, in other words, you have to be licensed in the state where you're billing and you're practicing. And so that really is a state requirement. You can be waivered, so a person can be licensed in another state, and we essentially can bless their credentials and say they're eligible to accrue hours to become licensed. But essentially, it is a state requirement that wherever you're practicing, you have the credentials commensurate with that state. For telehealth, that we've been using, thankfully, we've really not run into that issue per se. Most people have been Bay Area or California certified, so we've not run into that. But it really, essentially, a lot is something that the state would have to address. What they have told us and signaled to us is that we thought that the flexibilities we were given because of the pandemic would have been gone by now, because they just signaled to us in March, but they have extended them. So we are still able to do a lot of the telehealth that we lifted up really fast. We believe we will still be able to do the telephonic work. What we will change, we think it will go back to normal, is when a person now by phone can do an assessment, and that will revert back. You'll have to be in person and see that person in order to do the assessment. So that really helped to some degree because it enabled people to quickly make some moves, but that will go back to pre-pandemic.
Okay, if everyone doesn't mind, there's another chat question. It says, in 1 year, and this is the writer, not me. In 1 year, I had this experience twice. My son was placed in an unlicensed board and care because there aren't enough licensed board and cares. But because a conservator can't oversee a person in an unlicensed facility, both times he lost his conservator. The unlicensed homes were not managed well, so he decompensated quickly, and in both cases was in crisis within weeks. The second time was within 2 weeks that he had tried to commit suicide. What is ACBH or Alameda County Behavioral Health doing to stop this revolving door?
We purchased our own licensed board and cares. I mean, it's just direct as that. The good thing is in my previous life at Alameda Health System, and I know it looks like I'm darkening, I don't have automatic light. So hopefully you can still see a shadow. I'm sure you see my teeth. So,
We can hear you well. So.
Okay.
You're fine.
In my previous life, we had procured organizations that have licensed board and cares, and they were certified by the state. The good thing, I see that it was fortuitous, is when I came over to Alameda, back to the county, we actually reached out to that provider and have beds now licensed. So we have, and this has been during the pandemic, we are slowly increasing our ability to do that. And you said it articulately, it's a painful experience, but Alameda County Conservator is a little different than some other counties. Conservator's office, where they do require licensed board and care. Some other counties want that, but they don't necessarily remove the support if they're in an unlicensed setting. But be that as it may, we've decided to increase that availability. We're also hopeful that even now, even though our housing unit has moved over to our parent company, Healthcare Services Agency, we're hopeful that with Measure W, when the county is able to, which is supposed to support needs, including homelessness and housing, that will help eliminate some of the issues. The governor did allow us to retain, when I say us, I mean Alameda County proper, to retain some of, well, that's not very helpful. Wow, that just looks frightening. Has helped us to retain some of those hotels. And so we think that we will be converting many of them to more permanent housing. We do have a really close relationship with their housing partners, so we're presuming that we'll be able to take advantage of that. But at the end of the day, the bottom line for us is intervention, and we have increased by about 200, I believe, slots for our full service partnerships. And we think that by connecting a person much more closely, and remaining connected, regardless of where they end up being. That's been a hallmark of success for that person. And so if we can follow them all over the place, essentially wherever they go, that has helped them to maintain. So that's what we're attempting to do. And there's more to do, we think.
There was an add-on question to the previous one. It said, is asking, what is this place to which you refer? The board and care, I'm assuming.
The board and care, I'm not a fan of their name, but it's called Glom, although it's not an affiliated religious-based organization. It's Global Life Outreach Ministries. It just happens to have come from the zeitgeist of a faith-based organization, and they have probably hundreds of beds. Both they procured buildings. They have some in Tri-Valley area. They also have some neighboring counties. And so we found that they actually do probably well beyond what most board and cares do. They have hired nurses, they have case managers, they have on-site psychiatrists that will come and do consultation, and they're state certified. So for me, again, it was a win-win. So we try to work with them. And because of their background, they have much more of a desire to help the community and are a little more tolerant, we found, with some of the needs of our clients. And so it just was a perfect, so that's what they're called, GLOM.
Hey, thank you. Okay, there's another question around Glom. What is Glom's capacity?
That's a great question. There are several different sites and buildings, so it depends on what location. So they've grown. So I know they, in some areas they may have 6 beds, other areas they have 40 beds, they have 100 beds. So they're actually growing well. And again, we know that they have contracts with us. They also have contracts in Contra Costa County, which is not a preference outside of the county, but it just depends on their site. The first time that I had contact with them, it was a 6-bed unit, and that was one of the first ones. And in my previous life, we contracted, but they've grown tremendously. So it just depends on the site. But I don't know how they've done it, but they have managed to procure several different buildings all over. And that's why they have a lot of opportunity. We don't own, quote, all the beds, but we contract them fee for service so that our staff and team, when we find the need, we can then contract and then place a person in their facility, and we pay for that. And we pay them a rate that's higher than market because of all the wraparound services they provide, essentially.
Thank you.
You're welcome.
Does anyone else have any further questions? Okay, looks like I'm looking, seeing if there's.
I have a question while others thinking. From your experience, I know programs vary depending on the scope and all that. How long does it take to implement? An idea comes and it distributes. I know it depends what part of the county you're in and how it's working. Historically, how fast are we moving? How fast people see a difference? You're muted now.
I'm sorry, a difference in the system or a difference in the person's experience?
Well, you can split it up 2 ways and say what we in the system believe, how fast things are being deployed, because it's the layers, right, and the geographies. When I try to explain to frustrated people, including myself, and I understand even in the business world, things can be complicated, right? At the different levels, people see different things. But if you're down there with the sick loved ones who are going through crises, try to understand how all this comes together, right? And then from different people's perspective, what do they see? For us, and I'll tell you one example, biggest frustration, you mentioned the overcrowding in John George. My son's been there 7 times. The only time he got care in a hospital first round, when he was in Santa Clara, they kept him there 2 months. The doctor fought tooth and nail, got 5150, 250, 250. She kept going. And after 2 months, she goes, I can't keep him anymore. But I never seen that in Alameda County. Nobody fought for him. They sent him to San Jose once. They sent him to, and then at the time I even had private insurance. That didn't work. Now I'm in Medi-Cal, and I'm not holding my breath. We have a lot of good programs, but emergency services and locked beds, and hopefully those numbers are increasing. I'm just curious when we start seeing difference.
I appreciate the question. I think we're already seeing, as I mentioned, about a 25% reduction just this year. And why I think that's important is that it means that the people that need those beds will have greater access to, I mean, what is happening with your son, it to me is way too recurrent story that I hear that we want to change. It's not okay. What I think, if I can be frank, and I don't want to speak for Alameda Health System because they have their own board of trustees, we have a relationship with them as a county. But what I saw when I worked in Alameda Health System is about a 99.5% occupancy rate in John George.
Yeah.
And the 0.5 was just because if persons had the flu, they would close down some beds. Or if there was an event or something that occurred where they could only enable one person to be in a shared bed. What's interesting is there is a formula that is a quandary we're at. According to the state, every county basically has a formula. They look at the number of residents, they look at the number of Medi-Cal beneficiaries, and the state, and I don't mean, I'm sure people are aware, there's many state reports out there around Alameda County in general. But what I mean is the state proper, Department of Healthcare Services, will look at, because technically most people don't know, when a county, we are an HMO. So we're an HMO for mental health and we're an HMO for substance use. And that's why we're behavioral health. So we literally are a mental health plan. And the state will say each mental health plan has to have X number of beds per number of Medi-Cal beneficiaries per capacity in the community, depending on the number of residents. Technically, according to the state, they, by doing that formula, believe we have adequate number of beds. Now, this is Department of Healthcare Services. Now, everyone in the community, what you just says doesn't bear that out. And my guess is what I was mentioning before, that many years ago, we created model. We eliminated people's ability to release hold. So you have many people there that don't need to be there. And sadly, it becomes, you almost have to be the sick of the sick, quote. So, God forbid you're experiencing a difficult part of your life, but you're not just completely flooredly unable to resume your normal function. It is almost forced our system and John George to have to protect those beds for patients like that. And again, a lot of factors have led us there. So now we're chipping away at the process. And now we're having to undo that, which quite frankly, our system kind of set up. At the end of the day, the needs, and probably because of all the things that I said, it's just more fluid. People come to Alameda for a lot of reasons. It's great, but we are a thoroughfare, and we literally will have other counties coming here to partake of some of our services and benefits. So it's a chicken or the egg, but we are seeing an impact, and that's a good thing. That's why all we can do is hope and make some changes and pivots in our programming. So the things that we're seeing to enable other people to drop and release hold so that they don't have to go to John George. So John George doesn't have to admit them, only to discharge them, but John George can start to focus on healing. The other thing that probably you all are aware of, it's certainly in the community, is unlike Santa Clara, who, as folks are aware, a few years ago, discontinued access to any other county except for Santa Clara. In our Santa Rita jail, we don't have a therapeutic facility within it. So you do have inmates who rely on going to John George. So there are 4 beds in John George that are for inmates or that are for individuals. And that is a painful experience because they cannot forcibly administer medications the way that the current jail is. And so we're working with them now. A lot of litigation, there's a lot of things happening to help shift the paradigm. But I would add that some of those issues are the way that we structured Alameda County. It comes back many, many, many years. So literally, and I hope this isn't taking too much of your time, but I thought it was just something I share with people. When the inmates are transported transported, that sounds like sci-fi, but are transferred to John George, you know, what's painful is, number one, they're shackled, they're handcuffed. And on occasion, depending on their offense, the sheriff's office does allow them to be unfettered. But the problem is that when they get to those 4 beds at John George that are almost sadly always full, the inmates can't leave. So they're still detained. They cannot participate in groups. They cannot participate in any therapy outside of their room. So essentially, all they're able to do is medicate them to the point of being able to be returned to jail, not to return to functioning. And unlike Santa Clara, as you know, some people may be aware, they actually had a facility inside. So you had inmates and people who were struggling, but they didn't have to also come into the psychiatric inpatient unit. So John George, the way that it's configured now, and we're working with them to see if we can shift a lot of this paradigm, I believe that's why we're at in some of the places that we're at, because essentially they only have 69 beds, 23 on each unit, on their inpatient unit, 4 of which are used for inmates, for example. And they have to have care, and they need to have care. However, it's very similar to what you're describing. And it became an issue. The more Alameda County's need has grown, we've not caught up to the demand. And that's my experience, and I think the reality that we're struggling with. So that's why, again, for us, we're looking at things in custody, whether it's John George, jail, community. We have to tackle all of them because we're seeing patterns in terms of how much people are able to utilize the service because of that.
Yeah, I don't want to manipulate the conversation. Everyone jump in if you need to, but just so he was hospitalized 7 times since age 19. And first time he saw a huge man break nurse's nose in front of him. And, you know, they're all obviously very sick there. And he was so traumatized. He doesn't want to be there. And I'm trying to help him understand that the hospital or the police are not the enemy, but it is at the time for him. And now I see the difference. First of all, they do go to the local hospital, except Valley Care. Last time he was there, they lost him his clothes, and they had to move him to another facility with no clothes. And he was trying to figure out what's going on. He was very frustrated, but he decided he's not going to make a scene at that point because that will just keep him there longer. But he has no faith in the system and no trust in any of it. So we're trying to help him understand, you know, things can happen. It's just the process, and it's people, the mistakes happen. He made his share of mistakes too. So trying to be as patient as we can. But are there no other hospital outside of John George in entire Alameda County? I mean, private hospitals don't have any psychiatric beds?
They do. They do. In a perfect scenario, for example, we buy beds, quote, at Alta Bates, for example, county beds. What it typically looks like is if they see or they treat individuals who are Medi-Cal, who are underinsured or not insured, we will pay them to have a space in their hospital. So we do have relationships with private hospitals. And what we try to intervene on, and if I'll just be frank, is that we don't want there to be transfers to John George just because John George is seen as a county hospital. We want our private hospitals to treat the needs of the community, regardless of whether they're private or otherwise insured, but it does occur. And what you just described is essentially what I was speaking to. It's unfortunate, but that the scenario that you mentioned, the person being hurt, is what will occur in a system where there's limited number of beds. Then the prioritization sadly has to go to people who are most at need, and it becomes a very complex situation. So there's a lot happening around that. But
well, that incident was an emergency room where I've never been inside John George, that room, but apparently it's an open space. They're just cots lined up, and all these very sick people. We have problem managing one person at home, and yes, they're starting to get medication, but they're like all of them lined up in an open space. which I understand, at least with COVID, numbers reduced drastically, but
Yes, there was a limit of 25. And for those that don't know the history, just I thought was interesting. John George's PES used to be an inpatient. So if you ever Google the number of licensed beds that John George has, it says 80 at the state because it has 69, 23, 23, and 23 on the 3 inpatient units. And then there's 11 beds in the PES. So there are 11 single rooms, and there's also essentially a triage area where there's some rooms and spaces. And in my previous life, they were working to cordon them off to provide support. So the cots on the floor and things like that don't happen as much, not only because of COVID, but because they have found ways to change and divert the way that they saw patients. But you're right. So anyway, I say that to say, because there was a greater need historically for psychiatric emergency, county proper made a decision to, and AHS, to decommission those 11 inpatient beds to more of a what we see today.
yes.
And again, that was 20 years ago, and now we are at 2021. So it's time to kind of continue to reevaluate, and that's what we're doing with them now.
Yeah. Well, one of the things that surprised me, and I've been submerged in mental health issues last 7 years. At one of the conferences, I heard a director, really high level, I don't know his title or the name right now, but what stuck with me is he came from East Coast to California, and his comment was, in East Coast, when somebody thinks they need help, they go check themselves in a hospital. In California, exclusively 99% or whatever, some enormous number is all 5150. It's just like, it's so bad that I don't see anyone checking themselves into these facilities. It's all, 5150. It's incredible. I mean, I don't know if that's good or bad. I had a friend from New York who's recovered, sort of kind of dealing with the issue. I wanted to understand what she went through. She says, I checked myself in, and I look at our process. There's no room. Who's going to check themselves into John George? I can't imagine that happen. And I know the process. I think I know the process.
Well, they had about 5 to 11% volunteer. They do, but it goes back to what we were saying. I mean, you're right. I worked on the East Coast and the East Coast hospitals and so forth. And the difference is that John George is a county facility. And although the state metric says it's sufficient, it has exceeded its needs and demands in our county. But I think you are picking up on something very real. So that's what you see. Less people self-electing to go to John George. There are some, and most of the ones that are there don't want to be there. And they're the ones that remain are individuals oftentimes that really have the greatest need or have the most trouble returning to stable functioning. So it's almost unfortunate if you're able to improve even a little bit, you may not be able to remain just because there's so many people that have need in our county, whether or not they live here.
So it's like comes down to when we build all these houses and there's kids that need to go to schools, we build new schools, right? I mean, the county is doubling, the population is growing, and we know mental illness is percentage of it, no matter what, right? No matter what equation we look. What can we in NAMI, what can we in FASME and all these organizations do to bring this point across, and not just words, but to move the dial?
Well, if I can be, I'm choosing my words. Advocacy is important. I mean, first of all, let me just say that's an easy thing to say. Advocacy is helpful. I think I saw it in the chats, although I lost it, so I don't know how to click on it, and I don't want to hang up, so I'm not gonna. I won't look for the chat.
I'll read it to you.
Okay. All right. There was I saw a question around. It escapes me now, but essentially, Fairmont campus, for example, and this, I know you all may not be in the area of Fairmont, but the Fairmont campus, that's where John George is. That's where Villa Fairmont is. That's the subacutes. Cherry Hill is there. They have a lot of outpatient facilities. They have when we were one big happy family as a county, the board, excuse me, oh my word, the rehab facilities are still there, the Alameda Health System runs it. So Fairmont campus was designed to help support the county and community needs. What we find, and I've been in lots of different efforts around, i.e. homelessness and housing, is that sometimes there is a desire by the county and by community, but not in my backyard. And that is a challenge that many of our board of supervisors wrestle with. So I'm trying to choose my words to say it. And I've been on those meetings and calls where there have been concerns about John George patients discharged, and we need to find another facility to put them, but just maybe not in this particular area. So, we'll have candid conversations with our board, but they also have constituents. And you have very different parts of the county. You have Oakland and Fremont, you have Pleasanton, you have Castroville. And I think everyone would agree that it is a need. Although I've seen that in very many would prefer that the facilities occur not necessarily in their own area. So in terms of expansion, things like that, it is met with some resistance. There was some county created some homelessness programs on the Fairmont County campus, and that was a complex issue. But I think there's more to be said. And I think the good thing is there's a lot of things coalescing at this time. And so advocacy is important. And just know that the county and the board of supervisors are all, they all are very different, but they are committed and also want to respect the needs of their communities. So we're trying to figure out how we can do that and have people partner with us, because people have very different opinions about what can be, what should be in the communities. And that's been a hard place. But I wanted to, I know I will defer if there's any other comments, but I just wanted to make sure I covered a couple things, not much, but just my soapbox, but I'll defer if there's any chat items that I didn't answer. I haven't.
There are 3 comments, or I'm sorry, 2 questions and 1 comment. Would you like me to read them out now?
I'm glancing. I see one about.
Let's see.
I see one about the litigation, and thank you for acknowledging that I can't be. I can't be too specific. I have to admit, one of the things when I said yes to come back, I noticed that I would be walking into litigation, but I'm blessed and I feel happy to be back. Yes, that is a quandary in terms of, as for those that are looking at the DOJ reports and looking at the DRC reports. It used to be a juxtaposition, meaning the DOJ, if you think about it, or I'll even be specific, it is public, so I can talk about this part. There is a litigation around Babu that's in the jail. There is litigation or a concern with our system on the outpatient side, and that's DRC. DRC's primary goal was to not have there be so much of a reliance on John George and Villa and subacute. So we know that there is a desire to have more beds, but the state's position through disability rights was to not do that, to instead focus on the outside. Now, DOJ, the Department of Justice, is the federal body that is also looking at Alameda County. They're concerned with everything: jail, inpatient, outpatient, and everything. So we in the department and the county are looking at all the different feedback, and sometimes it may appear mutually exclusive, but at the end of the day, we just know we're gonna have to do both. We're gonna have to make sure we build more communities programs, outpatient. We've also started in the pandemic a diversion program from state hospital. Some of our clients were languishing in the jail. And so we now have we have beds. We basically bought them for ourselves from other counties that were utilizing our subacute beds for our diversion from state hospital. So people can go there and stay and restore and then be released and so forth. So there's a lot of things that we're looking at, but that's kind of what I'll say, that it is a balancing act, because each of those bodies have different thoughts on what needs to happen. And at the end of the day, we're just responsible for everyone. So
So I do have a question tied around that. So you're telling me the state is interested more in the community type programs. Why do we have such a high 5150 rate? And you know, and how much of it is how many people are doing repeat relapses in and out of John George or any other hospital, and if a person needs more help or more, you know, wraparound, more professional peer, you know, I just don't understand. To me, that would, yeah, maybe I just don't understand the rationale. I would love to read some documents on this so that I can more clearly understand this, because all I know is that a conservator and a bed are the two things that saved a life, and that life was my son's. So those two elements, and this was inpatient for a year. So no, I'm not saying everyone, because I'd probably be the worst person in the world wanting to, but you know, when you don't have a choice and you're that ill, how, I just have a lot of questions around that. I'm not comfortable. It's good to know that that's the state's position. And don't get me wrong, I think it's great if someone can work it, but not everyone can. My son can't. He's in a board and care. He's got full wraparound. He's not in this county because I couldn't find the help for him here. He's in another county. So, you know, a lot of questions that I have, and I'm still stuck on the fact that Alameda County has the highest 5150 rate. I mean, does that mean that it's easier to get help, or does that mean that a lot of people are getting sick and they have unmet need? So those are the things that for years I've been searching and seeking out what that answer might be. Maybe there is no answer. I don't know, but I don't even know if my question.
Add follow up to that, and that will be complete. So the service, the care, and the follow up when they leave the hospital, there's no follow up. They just can't. There's just too many. You know, there's no follow up. I know when we left Santa Clara, there was follow up the hospital there, and they made sure he had last time I was in John George. I called them, talking to the doctors, and I thought they're going to keep him until I go there. I thought that was clear. I was going to talk to the doctor. When I was driving up, my son was walking away from the hospital, half a mile down the road, in the gown, in the pants, because he didn't have much clothes when he was taken in. And I was shocked. I was totally shocked. But, you know, they said, it's COVID, we can't hold him. Oh, okay, then let's send him out. It's COVID. So, I mean, in its unique incidences, I say that, Karyn, I just want to stop you and say, thank you for what you're doing. I mean, I know it's a tremendous amount of work. I work in a corporate world in high tech, and when I submerge myself in mental health, I realize it's the most complex issue there can be. And it's difficult because you got the mentally ill who don't understand what's going on with all their own delusions and anosognosia going on. So it's very complex. And families, we're the only ones, like, we have thick skin. We just can't give up, right? We have nowhere to go. There's insurance companies, there's doctors, there's rights, there's HIPAA, there's hospitals, there's insurance. I mean, we don't know where to turn, and we all have each other to say, okay, what can we do? So we're not just complaining here. We're just, this is therapy, think of it that way. We're educating ourselves. So I don't want you to think that we're grateful for you to be here. And I know you're tired, you come here to help us, and we don't mean to dump our problems on you. We're trying to, so this is a community issue. It's not just about my son or her son or the others. It's we take those unique cases, we bring it up. We have a community. For all of us here, there's hundreds that don't even have the capacity or know how to speak for their loved ones.
Well, thank you. I appreciate that. And I don't take anything personal at all. I couldn't because
You're
there's a lot of,
awesome. You're awesome.
oh, thank you. I'll tell my family though. Thank you. I appreciate that. I mean, this is real. What people are going through, their families, their lives is real. And so everybody has a right to feel and advocate. And so that's our job, to hold it and hold the space. So I understand. I do. And again, I feel privileged to, and I'm glad I came back, and I know there's a lot of work to do. I will not, thank you. I will not be bored. That's for sure. But I think there's so many things that I'm looking forward to changing. So I appreciate that as well. If I can, I would love to just share a few things if I can. And I'll be quick, and I hope I won't be too fast. I hope people have people heard me talk about the biopsychosocial spiritual approach? Anyone else?
No, I'm interested.
No, yay, thank goodness, because my kids think I'm a YouTuber now because I'm like they're like, are you doing that again? Yes, because I believe. So the only thing I would love to leave it, thank you very much. I would like to leave you with is that in terms of whether it's your loved one or whether it is your own self, to remember a four-pronged approach: bio, psycho, social, and spiritual. And I'll break each one down. Biological, and especially during the pandemic, not only looking at obviously the vaccines, COVID issues, have they eaten, are they hungry? But when you're coping and when your own self is needing to recalibrate, I strongly recommend you picture a table and you think of biology. You think of, have you had enough sleep? Have you thought about what your medications, whether that again doesn't have to be psychotropic, but it could be a loved one's heart rate, whatever that is. It's extremely important, particularly now, because we are finding that as you can imagine, a regular traumatic event, it is hard. Now imagine a trauma that has gone on for an entire year. Our brains don't really work that way. We are made fight or flight or freeze to kind of go through something and begin to recover, but we've really not been able to experience that recovery. So your ability to think clearly is different. You may find, I'll just speak for myself, you're more annoyed biologically, you have a shorter fuse, or you may be more laissez-faire or physically more lethargic. You don't have COVID per se, but you're just feeling it differently. So make sure that you're taking care of yourself on a biological, on a very primitive, pragmatic level. And it also goes with your loved ones. And I remember being young, I've lost both my parents now, but my mother, I would say something and she'd say, "Honey, have you eaten?" And I'm like, "Have I eaten? I'm telling you the existential meaning of life." But it was true. So remember that, biology. Psychological, again, thinking of your own mental health, whatever that looks like for you and your caregiver. Are they depressed? Are they anxious? If they are there strategies they can cope with? And remember everything that I said in the middle of a traumatic event. It literally, you are taking shallower breaths, and they'll probably be doing way more studies. And remember this meeting if that does happen. But when people are stressed, your respiration speeds up, and the depth of the respiration narrows, and the less deep breaths you take, the less oxygen in your brain. And so you might find that you're not quite on point. My kids joke, "Mom, is that short-term memory loss?" And I say, "I don't think so. I forgot if it is." But it's real. And especially during this pandemic, I would encourage you to think about how the person's doing on a psychological, or yourself. Literally, how are you doing? And again, take your own temperature, do what you need to do to maybe watching TV, limiting the media, thinking about, because there's so much pain going on. There's a little bit of joy here and there for sure. We want to celebrate that. But we've had to, in our own family, just think of ways to connect. For those that know my last name, I love sci-fi. My last name is Tribble. I used to love the Tribbles and Star Trek. I watched the originals. I'm dating myself, but we'll watch a zombie movie. Okay. I'm telling way too much our business. We've got a go bag in a zombie car, whatever it needs to do, but really attend to yourself psychologically. Third one, and I know I'm bumping up against time, so I'll get through this and hopefully it's helpful. I really hope that Thank you that you take a listen. So there's biology, biopsychosocial. We already know clearly what the pandemic has done. It has increased social isolation. We know that. But there is a way to connect. And even though this is one dimensional, we really encourage you to think about how you can get your social needs met. Many people in the faith, i.e. we're congregating. You can't congregate in the same ways that you can. Kids can't be in school. So think about how am I connecting with my loved ones? Am I FaceTiming? Am I watching a movie? I think it's Sling or Swing or something. There's a lot of things, texting. If you can be in person, if you've been vaccinated, whatever it is. But if you can gingerly think about how you're getting your social needs met, it's really important. And one of the things, again, I don't want to be political, but as you saw back in January of this year, when people didn't think of all those needs they, i.e. got their social connection politically, it meant everything to them to demonstrate that political affiliation, even beyond reason. And one would imagine if this was 2018, many of the people who engaged in some things that are going on these days probably would not have. And we would argue that there's a lot of unusual events occurring that are impacting how we're navigating in this world. So again, thinking about how your loved one and you are really getting your social needs met, whatever that is. Ironically, those kids who were playing, my kids used to be way too much in the computers, 20-something-year-old, and like, is she home? She's somewhere. Ironically, those kids who played those games and were connected, that's how they got their social needs met. And so we have worked with some of our adult parents and so forth. Don't take away that which have given them wholeness on a social level because they can't congregate with their peers. So that's social need. And finally, the last one is spiritual. And this one, I certainly do not mean, again, I happen to be a person of faith, but not proselytizing. But what's important is that people have an existential awareness of who they are, what spiritual connection they know, what they believe in, what gives them health, what gives them wellness. When I mean that, I mean literally on a metaphysical level, and that again is extremely important to remain connected and feeding yourself and your recovery. So if you can think of, biopsychosocial, spiritual, I am just here to tell you it makes a difference. People have asked me, how are you so balanced? Well, because I pay attention and I'm practicing what I preach, and I'm working with our family, working with our staff to remember to see some joy in your life and remember those things. And if all else you forget, just think of being on an airplane. For those of us that remember when the thing dropped out, and remember when the steward or the stewardess told you to do your mask first before you have to do that. So self-care during this pandemic is not self-care, it's self-preservation. So you will need to do that. Look at the 4 prongs of the table, and then you'll be in a better position to be able to support, your loved one or whatever that looks like. I'm at 8:30. I'm going to stop talking. So I hope that was helpful.
Thank you so much.
You're most welcome.
This was great. I really appreciate you coming back. I think it was October, so it wasn't that long ago. And, we're definitely going to want you to come back. Yeah, but we'll wait an extended time. And, maybe we'll be in the same room. Maybe it'll be a
new day.
Yeah, no, it'll be, I'm excited at the prospect. So, take good care of yourself, and everyone take good care of yourselves as well. And I thank you very much for joining us tonight.
Thank you. And thank you all for allowing me in the space. And thank you so much for the questions and feedback. I took it to heart, and I wish you well. Be safe. Thanks a lot.
Thank you very much.
Thank you.
Thank you.
Take care. Have a good evening.
Thank you.
Thank you. Thanks so much.
Thank
Most
you
welcome.
all. I did put a couple of things up here, a flyer.